Welcome. I'm Ogan Garel, your host for InTimeTV's Insights in Medicine. This is our inaugural show. We have a great show ahead of us in the next hour with a fabulous guest. Let me tell you a little bit about Insights in Medicine. It'll be covering bridging the clinical side, the scientific side, and the business side, really getting under the covers of healthcare and medicine with distinguished guests and individuals, the thought leaders from the business side, the scientific side, and clinical side. Today we have Dr. Anderson Hedberg, the former president of the American College of Physicians, and our focus today will be on the present and future of primary care. We have the distinct honor and pleasure of having Dr. Anderson Hedberg as our guest today. Dr. Hedberg has been one of our nation's foremost medical internists, having served not only as patients, but most recently in 2005-2006 as president of the American College of Physicians, the leading organization, the second largest physician organization with over 116,000 internists as well as medical students, a very influential organization, medical specialty organization. In that capacity, as well as throughout his career, he's had an influence over general internal medicine in the nation, having testified at Congress, and we'll talk about some of those very interesting deliberations over the course of the next hour. He's also been involved extensively in academic medicine, having served on the faculty of the Rush University School of Medicine, directing the section on general internal medicine and serving as assistant chair of the Department of Internal Medicine. Dr. Hedberg, welcome. Thank you very much.
Thank you.
It's a pleasure to have you.
Pleasure to be here. Right.
Perhaps you can fill in, I gave a whirlwind introduction with a little bit about your background from yourself and some of the decision points in your very illustrious career, perhaps.
Well, I don't know if there are many important decision points, but what I've enjoyed the most is taking care of patients.
Mm-hmm.
And I spent 40 years in practice and enjoyed doing what we do, applying the great science we have in medicine today to the care of the patient, and getting to know my patients in a primary care way. As we all know, that's a special way. And getting to know them and having the trust of my patients and enjoying meeting them and following them throughout their lives. And many patients I took care of for many years. So that any decision point I made would come out of that experience. One thing I did that was very gratifying for me was to be with the American College of Physicians for many years, and then eventually their president. And it gave me a chance to step back from the doctor-patient relationship, which I treasure the most, and try and apply some of the things I learned clinically and about people to the global scene of internal medicine.
And actually that brings up one of the questions. I've been reviewing all your accomplishments. Let's start with a big topic and focus on some of the more particulars from there. You gave a speech near the end of your presidency at the American College of Physicians entitled State of the Nation's Healthcare, where you highlighted the importance of primary care in our nation's health. Perhaps stepping back a little further, it's a hot topic. How would you characterize our nation's health care today?
Well, at the time we put that press conference on at the National Press Club, we had really come to appreciate a crisis in primary care. So I feel that that's going to be remain a subject today, and I also feel that that's a very important subject for America at large, because you have to have a strong primary care base in any sort of medical enterprise, any sort of social system of medicine in any country. And we're beginning to have that base decline, which it shouldn't be. I'd like to mention three other major issues that I think face America today. I picked them out. There are lots of issues, but the issue of diversity is very important. And when I talk about diversity in this sense, I'm thinking of the uninsured patients who really get a different level of medical care. When they don't feel well, they aren't able to go to a doctor because they don't have one.
Yes.
Their illnesses often are prolonged, and before they even get to the emergency room, which they use for their medical care. And the outcomes on a whole variety of diseases have been shown to be poorer than what the average receives, both here and abroad. So I think that's a very important issue and gets us into the subject of universal health care.
Yes.
And taking care of our whole society. There are now 46 million uninsured in America. A third issue that's been very important to all of us, particularly at the American College of Physicians, because we are the standard bearers for 120,000 internists and medical students and residents in this area, is the quality of care. And there have been concerns in America beginning several years ago now, when the Institute of Medicine came out with their program on the chasm of quality in America between what we know about medicine and what we actually do for patients. And even studies that have been done by Rand Corporation and the University of Michigan has shown that about 50% of the measures that we know, evidence-based, would help patients in acute and chronic conditions and in preventive conditions are not applied at the bedside or in the clinic as they should be. That's a big problem. And the last item I will mention in this group is the cost of medicine. We are the most expensive country in the world by far in terms of taking care of our patients on a per capita basis. We have an average of over $6,000, and it's twice the average of all the other developed nations, 35 developed nations that were measured, and it's over $6,000 at this point. And it's a big, big problem that's not going away, and that is unsustainable the way we're doing it.
Well, perhaps those are very obviously critical topics, and I asked the question because we're in an election year.
Absolutely.
And everyone from the former president of the American College of Physicians to the man on the street is really grappling with these issues. Maybe we can cover a couple of them, because I want to focus on the primary care aspect. In terms of quality of care,
yes,
the second item you mentioned.
Right.
How does primary care fit into that? What are some of the programs or initiatives that primary care in particular can affect the quality of care?
Well, there are some very interesting studies on this. In the international level, we do not bear well in measuring quality, which is a shock to a lot of people. But of those 35 developed nations that I'm talking about, and the Commonwealth Fund has done a lot of work on this, we are pretty far down in most medical outcomes. And the reason that we are dragged down when you look at it on a population basis is because of mainly one of the reasons, because of the uninsured who have poor outcomes.
So we're going to take a short break, follow up on quality of care as well as cost of care. This is InTimeTV, Insights in Medicine. Our guest, Dr. Anderson Hedberg. We look forward to following up on these topics. Stay right there. We'll see you shortly.
I'm a lion.
Yes, you are. Come here. Let's see how this looks.
Hey, how's my little horse?
She's a lion.
Yes, she is.
You don't have to be perfect to be a perfect parent. When you adopt a child from foster care, just being there makes all the difference.
Come on! This way!
Who is that guy?
I don't know! Hurry up and get behind us!
I know!
Come on, get up!
407 years ago.
Think history is a little scary? Then log on to LOC.gov and see how much fun it can be. The Library of Congress at LOC.gov.
Pants, pants, pants. I am folding the pants. The pants are long. Do they go on my head? Do they? Do the pants go on my head? No, they go on.
Everyday moments can become teaching moments because learning starts long before school does. Give your child the start they need at bornlearning.org.
I wish I could go back. Back when I didn't need someone to do my hair. Back when I could still say my husband's name. Back when I could have called 911 but didn't. Back when I first felt the warning signs of a stroke but did nothing. I wish I could go back, but I can't.
With a stroke, time lost is brain lost. At the first warning signs, take action immediately.
Well, Welcome back. I'm Ogan Gurel with Insights in Medicine on InTimeTV, live web TV. Our guest, Dr. Anderson Hedberg, former president of the American College of Physicians. Before the break, we were talking about the state of our nation's health care. Dr. Hedberg had mentioned several points, and we were talking about quality, and in particular, how primary care figures into quality of care. And you were referencing some studies, and we had to take a break, but I look forward to hearing more.
Right. So the countries internationally in this group of 35 or so developed countries that we're part of, they have very strong primary care bases, and they have 70% of their doctors, roughly, who are in primary care. 30% are specialists. Well, we have a reverse situation in the United States. We have only 30% in primary care, and 70% specialists. And so we don't have a large army of primary care doctors. And now they're beginning to drop away. Medical students and residents are not going into the field, and doctors are retiring early and leaving the field. So the numbers are growing smaller, and there's some reasons for that, which we can get into. But it also appears that when you look at primary care and you look at the countries that have a strong primary care, they have better outcomes than we do. In the United States, some studies have done by using Medicare data, and it's quite interesting. The states that have higher ratios of primary care doctors to specialists have measured higher quality, and furthermore, at much less cost.
Right.
So this is interesting data that's come up, and why would they have this difference? And the reason is probably when you have a strong primary care base, you have more prevention, you have more detection, you have better triage of patients to the specialists when they need them, and you have a more informed opinion about the common illnesses they have.
Those were rather general studies across populations, not on a specific disease.
Correct, yeah. Although the outcome studies are on specific diseases.
Right.
And
the reason I mentioned that is there's a very interesting phenomena, as you know, of disease management.
Of course. Yeah.
How does that figure in all this? Because I'll tell you my take on disease management. I think it's very important. Obviously, Medicare is looking at that, but it almost seems as if disease management, in the conceptual sense, and disease management being frameworks on a institutional level that follow patients, monitor patients, etc., it would almost seem to me that disease management is becoming or is there as a substitute for the dearth or decline of primary care physicians.
Well,
how does that relate?
I think disease management is really oriented, as it's set up now, with certain companies that will have people that follow certain diseases. So you have a disease management person watching your congestive heart failure. If you have diabetes, you'll have another one doing that. And our take on this in the development of primary care medicine in the future is that the primary care medicine should be in a medical home, which incorporates, which is run by the physician, incorporates nurses and other helpers, and that we will do the disease management. Why should there be a middleman in this thing? Now, I'm not saying they don't do good work. I think they're better than has been happening, and they have showed some improvement in the quality of care. But the overall person who's taking care of the patient certainly should be able to do this with the proper attention.
Right. So to some extent, there's an overlap between the role of the primary care physician and the disease management.
Of course.
And to the extent that there may be a primary care gap, which we'll talk about a little bit later, that's what these companies are filling to some extent.
They are.
Right.
Yes.
Now, that leads to another question about cost. We
Correct.
had talked, one of the reasons for disease management is not just to improve outcomes. One of the reasons for great primary care physicians is not just for the quality of care, but there's been talk of a cost element to this.
Well, keeping our patients out of the hospital who are not doing well at home, and the disease management person calls, how are you doing? Not well. Well, then get in touch with your doctor, or we'll get in touch, make sure we get in touch with your doctor for you. And that alerts the medical system to take care of this problem before it, for example, somebody with chronic congestive failure has gained 5 pounds in the last day. Well, that's a bad sign, and we need more diuretics. We go to the doctors for that, and so on. But they're really middle persons, and really the call could come directly to the medical home or the doctor's office, which is the medical home for that patient.
You'd mentioned some studies about quality of care and documentation in some states, Medicare data and so forth, that primary care doctors reduced or increased the quality. Have there been comparable studies where an increased proportion of primary care doctors have reduced the cost for those systems?
Well, this is being studied as we speak, and Medicare has a couple of projects out there now where they're looking at the office structure and how an office is run, particularly the use of computers, the use of reminders, the use of guidelines in the doctor's office, which can reduce hospitalizations and can reduce the cost of care. So I think the cost element is a big part of what we want to accomplish. And I think what we're talking about here, these techniques will do that over time. But it's being studied specifically right now.
Right, but those studies aren't out yet.
No. There's some, one of the studies is a 3-year study, and the first year has been reported, and it's very favorable so far.
Right. Well, let's focus a little more directly on primary care. In that speech that you gave,
yes.
You had talked about the importance of primary care and said it, in my opinion, in very inspiring terms, and I quote, "A patient's relationship with their primary care physician is something that can develop and continuing over the course of years. You see your patients through major life changes as they both grow up and grow old." So what efforts have, I mean, this is very inspiring, and I think any young person would aspire to this sort of ideal. Why are people, young physicians, moving away from primary care physicians? What's being done about that?
Well, of course, we want to get back to the doctor-patient relationship, because it has become, well, shorter amount of time being spent by doctors with patients because for various reasons. And we should get into that too. And that's the nexus of all we do is the doctor-patient relationship, and getting that well done. But I'll give you several reasons why doctors young doctors, medical students and residents are not choosing the field. And the figures are alarmingly in their drop. I mean, it's about 50% less in family practice and internal medicine of young people going into that over the last 8 or 9 years. And the reasons have to do with a number of factors. The first I would mention is the low reimbursement rate for doctors who are in primary care.
Well, we have a quick break coming up. Okay. It's a good time. Let's talk about those factors. This is InTimeTV, Insight to Medicine. Our guest, Dr. Anderson Hedberg. I'm Dr. Ogan Gurel. And stay right there. We'll be back in a couple minutes.
Once they've outgrown their toddler seat, they're still not ready for adult safety belts alone. 4'9" is the magic number. Until then, kids need a booster seat. Make sure your little pumpkin gets there safely. Visit boosterseat.gov.
Protect yourself from mannequinism. Volunteer. Vote. Stay informed. It's easy to get involved.
Can I ask a few questions about the apartment on Park Street?
What was your name?
My name is Juan Hernandez.
It's been rented.
Hello, my name is Sanjay Kumar. I am calling about the apartment on Park Street.
It just rented.
My name is Tyrone Washington. I'm calling about the apartment for rent on Park Street.
It's not available.
I use a wheelchair and...
It's gone.
Hello, my name is Graham Wellington. I'm calling about the apartment for rent on Park Street. Is that still available?
Yes, it is.
Oh, it is?
Housing discrimination is illegal. If you think you've been a victim, call us.
Before you start an online relationship with a guy, think about how it could end.
Welcome back. I'm Ogan Gurel for InTimeTV and our program Insights in Medicine. Our distinguished guest, Dr. Anderson Hedberg, former president of the American College of Physicians. We were talking about the relative decline of students and young physicians going into primary care. And just before the break, we were talking about the factors involved, and Dr. Hedberg is going to talk about some of the programs by the American College of Physicians and others to ameliorate this.
We sure will. We'll finish the factors first.
Yeah.
And I was talking about the low reimbursement, which is really about half of what the average specialist makes in American medicine. This, of course, is apparent to students and medical students, and they pick it up right away. Now, the figures that you can give on this in terms of numbers sound like a pretty good living for anybody in our society, but the problem is the costs are just gone up tremendously. American Medical Association did a survey recently, and over the last 15 years, the costs of doing practice in an office have gone up 40%. The Medicare fee schedule has only gone up 20%. So doctors have been losing out year by year. And when you're a slim margin of being in primary care, or the reimbursements are low, you have the margin cannot be enough sometimes to stay open. So many have closed their offices and left. And of course, medical students see this and they say, gee, I have debts, and the medical student debts are now 150 to 170,000 averaging, and they have to start paying them off, excuse me, the minute they get into their residency programs. They don't have much money at that point, and they don't want to get in the hole that way. So high costs to do business, low reimbursements, and it's adding up to a bad mix. And the student debt, which makes them very insecure.
Yes.
Furthermore, the field has a lot of administrative chores because of the number of referrals that are done, because you really are the keeper of the patient's health, and you have to direct them in the right directions. Some states have 25 insurance companies.
Yes.
You have to hire more people to take care of all these forms, and most doctors are very aware of this. What has happened is primary care doctors in practice have tended to increase their patient loads, increase their volume to make more money to stay open. And the result of that has been shorter times with patients, which patients complain about in various surveys and polls. And many doctors feel a loss of quality from that effort. And the younger doctors, of course, want to have good families, children, homes, buy a house and all this. And they look at this and they're saying, well, I'll become something else. And we're really suffering from that. So we have to try and overcome that. And the American College of Physicians has worked very hard over the last few years to try and do that. And that's the essence of much of the work that I've done the last few years. And I'd be glad to get into that part of it, if you wish.
Yeah, if you would. It sounds like
what can we do about it?
Yeah, what can we do about it? I mean, those are pretty challenging barriers, I would think.
Of course they are, yeah.
So what can be done?
First of all, we've worked very hard trying to reform a dysfunctional payment system. And there has to be some way to achieve a balance in medicine where the very important element of infrastructure, the primary care doctor, can feel comfortable in their practice and will not have to become such a businessman that the quality of care they give suffers, which we believe has happened quite a bit. So doing that is difficult because the government uses various formulas to reimburse for reimbursement. Medicare is working on a fixed budget. We constantly have new technology coming in which uses the fixed budget quite a bit. The primary care doctors mainly have the coding methods for payment, which are the evaluation and management codes, and those are just lower on the totem pole. We've had some success in raising those in recent years, but the relative-based value scale that's been put in place for some time now to try and do this has really not succeeded to bring a balance to the whole situation. So that's a tough nut to crack.
Yeah, in the 80s and 90s, I think it was in the late 80s, there was a relative value-based system, which
still is.
It still is, of course. I guess my point is that was, at that time, to bring a balance between the cognitive specialties,
correct,
of which primary care is definitely important, versus the procedural specialties.
Absolutely. Yeah.
So that was a big, I was actually in medical school at that time. I remember the whole debate around this. Has all that backtracked?
No, it hasn't backtracked. Progress was made, but not enough.
Not enough. I see.
And specialty medicine has, believe me, I am not against specialty medicine. Half our membership of the American College of Physicians are the cardiologists and
yes, right.
gastroenterologists and the 10 other specialties. But I'm saying that they will do better, and American medicine will do better if there's a better balance. More and more are going in that direction who enter internal medicine. In 1998, 54% of internists went into general internal medicine or primary care practices, and the remainder became specialists. Now, less than 20% are going into primary care. And I've been in states where they had residency programs totaling maybe 60, 70 residents, and only 4 or 5 people were selecting the primary care piece. But I think the reimbursement puzzle, the way the payment system is set up, has worked against them. And we're just trying to very hard, and that's part of our testimony in front of Congress. And there's an organization called MedPAC, which advises Congress, and they give a report to Congress every year on this. And for some reason or other, it hasn't hit home with the congressional people who make these laws. But we do visit them on a regular basis, sometimes on an emergency basis, to try and get this turned around.
If we backtrack a little bit, look at primary care in the broad sense, there are some specialties that have a primary care element to them.
Of course.
So, for example, OBGYN.
Absolutely.
A lot of women look to their obstetrician gynecologist for primary care. Certainly pediatrics has that. And then specialties such as geriatrics and even some of the more surgical subspecialties, almost like urology, for example, has a primary care component.
Correct.
How does that figure into the whole picture?
Well, we account for that in internal medicine by having a category of principal care. In other words, you can have a kidney doctor and very complicated renal failure, and usually a nephrologist will become the principal doctor. In other words, that means doing the primary care for a patient with a disease that's being managed by a specialist. That doctor wants to, because medication doses are very important. You see this in oncology too. You see it in transplant medicine and so on. And that's fine. And the principles we're stating having to do with primary care and the way care is delivered as a primary care person really includes everything.
Well, we'll have another break. It's Dr. Anderson Hedberg. I'm Ogan Gurel with Insights in Medicine. We'll follow up with some more detailed questions around primary care. Stay right there. Look forward to seeing you shortly.
2 words for you. Pop quiz. Ready? Name any funny movie. A drama. Name a mystery. And one more thing. Name the movie your kids saw today in science class.
Know what really matters. Know about your kid's school. And know about your kid. Find out 100 ways to know more, do more.
There's something about you, baby. I can't get enough. There's something about you, baby. I got you looking at me, I'm gonna call you bluff. There's something about you.
The smallest moments can have the biggest impact on a child's life. It takes a man to be a dad.
To the morning light. One day these rats were playing in the woods. One of some matches and that's no good. Listen to smoke before you give it a try.
Only you.
Don't play with matches. Don't play with fire. Cause there's nothing very funny about nothing very nice on a homeless mind. So if a gorgeous force is what you desire, don't play with matches. Don't play with fire.
Only you can prevent wildfires.
Fire.
Mom?
Dad?
How long should I wait for you?
If I'm at soccer practice.
What if something happens? Will you come get me?
There's no reason not to have a plan in case of an emergency.
Should we go to the neighbor's house?
And some extremely good reasons why you should.
Can you tell me?
Talk to your family about what you would do in case of an emergency.
Welcome back. I'm Ogan Gurel with Insights in Medicine, being aired live on InTimeTV. Our guest, Dr. Anderson Hedberg, former president of the American College of Physicians. Our broad topic is primary care. Just before the break, we were talking about various initiatives and programs to increase the amount of primary care physicians in society. And during the break, Dr. Hedberg and I talked about one of those programs, which is very significant. And please tell us more.
First, I'd like to just mention one more thing about the payment system,
payment
which I didn't get in. And that's that about 50% of what internists do in their offices has been estimated to be unreimbursed. And so there has to be some way of covering a lot of unfunded services in America. Preventive medicine is poorly covered. The preventive medicine codes aren't even covered by Medicare, not paid for. Furthermore, the coordination of medical care has to be paid for. Getting patients from one place to the other, really, and getting into the aspects of medical care, such as patient education and communication, that all has to be looked at from a reimbursement standpoint. But that gets us into the patient-centered medical home, which is a very important concept that's been put forward and seems to be really received now by many aspects of medicine as a way to go. Four associations, the American Academy of Family Practice, the American College of Physicians, the American College of Pediatrics, and the American Osteopathic Association have endorsed this plan, which is a new ideal plan as to how you set up a primary care practice, but can apply to anybody doing principal care for a patient in any specialty, but mainly for primary care. And what it does is it lays out what patients need and what patients want. And we want to design a system that is cost-effective, that goes in this direction. And many of the things that you will hear that's in this plan are being done right now by primary care doctors, but they're not as well organized as they should be, they're not as well reimbursed as they should be, and they haven't assumed the importance they should have in the total care of the patient. So this plan, really the four associations I talk about represent 300,000 primary care doctors, and we're all behind it. It has also been endorsed by many of the Fortune 500 companies, IBM and so on, and a couple of the major insurance companies are working on it, and the CMS, the Center for Medicaid and Medicare Services of the government, is mandated by Congress now to do a pilot study on this, a development study, demonstration project starting, and it will start at late 2008. And just let me go over very briefly what the characteristics are. Every patient should have, and the medical home means not the patient's home, it means the home of the patient for their medical care. It means the doctor's office in essence. But every patient should have a primary care doctor who gives comprehensive care, which means the total takes care of the whole patient on a continuous basis, and it can happen from the beginning of adolescence all the way to the end of life, or in family practice they do the whole smear. But in any event, emphasis is placed on teamwork, having nurses and nurse practitioners and physician assistants, whatever, work with you and do a lot of the tasks with you in the office that are ordinarily done. And that includes better communications meaning the use of phone, but also of fax and the newer email type of medical care that's developing, which is very important and going to be very popular, I believe. And electronic devices like a blood glucose monitor that transmits in a wireless way to a doctor's office, and a continuous form of care rather than episodic visits. All of this can be done without even coming to the doctor's office, and costs should be greatly saved by these types of things. The teamwork that's system-oriented in the office will include excellent patient education. The patient should be well educated on their disease, on the treatments. Goals should be set, plans should be made, and communication should remain open in between intermittent visits. And then also great emphasis on prevention and detection, And the last point, the coordination of care, extremely important. Patients complain so much about the fragmentation of care today, going from specialist to specialist. They don't know, nobody sums it up for them. They don't know what's up. And all of this coming together with proper health information technology, with the electronic healthcare record, and with the ability of the doctors to transmit information back and forth seamlessly, and for the doctors and the patients to communicate seamlessly. And the health information technology gives the infrastructure or the heartbeat to this whole system. And we think that put together properly, we will have better quality, we'll have better safety. We think, and these have been shown in other isolated instances in studies already, we also think that the office will become more efficient, the doctor will have more time to spend with the patient, and the costs can be better controlled. Part of the electronic health record, of course, is a clinical decision-making tool, an information tool for doctors, which has the guidelines immediately, so quality is immediately there. You can look at the guidelines, use them appropriately. You can look at the evidence-based studies. You can do it in the context of the patient, and we think that's going to be a big improvement. So we're working with these other agencies and these other employers and healthcare entities to try and help them set up this type of system. And as I say, there are 300,000 doctors in back of this. It will take some new reimbursement models.
I mean, there's obviously a lot of strong and powerful organizations behind this. Is there a single website that our audience can find information on
there's
this,
a new organization called the Patient-Centered Primary Care Collaboration. I don't have the website address here.
The Patient-Centered?
The Patient-Centered Primary Care Collaborative. And they are a group of these 4 organizations, plus various employers, plus an insurance entity or 2 that are working together now to put this across. I would recommend that they could go to the ACP online and look up patient-centered medical home. Just type it in, and they should get all the information they need.
So that's www.acp.
acp.online.
We're coming up to a break, and I wanted to talk a little bit about other aspects of primary care. In particular, as we return from the break, I want to discuss with Dr. Hedberg why I think primary care is more important than ever.
I'll go along with that.
Yeah, so stay right there. This is Ogan Gurel with Insights in Medicine, showing live on InTimeTV from Chicago, Illinois. Look forward to seeing you soon.
My pot of gold, your daddy's little girl till heaven home.
It's easy to tell if you've had way too many. But what if you've had just one too many? Buzz driving is drunk driving.
Hey guys, thanks for coming.
Are we in trouble?
No, you're not in trouble. I just want to set some ground rules.
Like what?
Well, remember last week when you hit Vinny in the head with the shovel?
I do not recall that.
Of course not. Well, it was pretty graphic. Too graphic for the kids. So I'm going to have to block you.
You know, I got to make this up to you. This is Vinny's watch, and I want you to have it. You deserve it.
Thank you. That's really not necessary.
No. Come here.
Welcome back. I'm Ogan Gurel with InTimeTV's show Insights in Medicine with our guest, Dr. Anderson Hedberg. Just before the break, we had talked about finding out more information about this very important and multi-organization, multi-agency program called the Patient-Centered Medical Home. And the best way to look at that is at the American College of Physicians website, which is www.acponline, one word, acponline.org. And as Dr. Hedberg mentioned, plug in Patient-Centered Medical Home. You should be able to find the information there. But mind you, it's not just the ACP, it's not just the American College of Physicians. It's quite an extensive collaborative. One comment I wanted to make, which is what I've thought about for a while, is there has been a thought that primary care might be, and I don't mean to be controversial, but maybe in the realm of all this technology and high-tech medicine and everything we can do, it's more old-style medicine. But my perception is, as all these technologies and as patients, you know, the aging of the population, more chronic disease, more comorbidities, multiple conditions, and so forth, I think that can even, that actually argues in our technological age for more primary care. There's nobody really to coordinate all that.
Well, I'm glad you brought that up, because what we're facing now is the baby boomers entering Medicare.
Exactly.
And in the next few years, 75 million will enter. And HHS, Health and Human Services, has estimated that we will need 150,000 internists, general internists, by 2020 to take care of this population. That's the internists alone, not the other specialties.
And these are older patients.
And right now we have about 100,000.
Right. They don't have acute conditions taken care of quickly with some procedure.
Right,
That's it.
Chronic
These are chronic conditions, multiple.
Figures are that 80% of the Medicare population, which is about 46 million people, 86% have at least one chronic illness. 20% have 5 or more.
Yes.
And they eat up 60% of the Medicare budget, which is now $400 million a year, more than 400. Billion a year.
Yes.
I'm really old-fashioned. No, it's billion a year. And they require a completely different type of medical care rather than acute visits. And that's what the medical home really can do. It's built for all medical care, but it's built really with this in mind, that the chronically ill, the multiple complex patient, which internists are really trained to take care of in our training, that this patient can be best cared for in this in a setting in which there is the communication, in which there is the patient education, in which there is the self-management, and in which their needs are met on a day-by-day basis. It is, in a sense, it is what could be called old-fashioned medicine. But I don't think the things that primary care doctors do will ever be old-fashioned.
Yeah, I didn't mean it that way.
We have to have a history, we have to have a physical, and we have to make the decisions. There is not a computer that will ever come out that can match the decision-making necessities of having somebody who's captain of the ship and watches over the whole patient and makes the really critical decisions that have to do with the patient's life. It's not going to come out of a computer. So the major functions of doctors, to know their patients, to have a great history, a great physical exam, and know the treatments that are available, and counsel the patient and talk to them and bring them into the decision making. This will never change. And no matter how much tech comes.
Oh yeah, exactly. And I think one of the aspects of medical care is, even in the context of evidence-based medicine and so forth, for a given patient, there's often not a definitive, this is the treatment.
It's called judgment.
It's called judgment. And also the judgment is not even only the physician's judgment, but to the extent that the patient's lifestyle or expectations, or, for example, even their pain threshold, whether they rather get some surgery to get some back pain taken care of, or they rather do conservative treatment, there's not necessarily one single treatment, and becomes a human aspect of
Exactly, but they should know the options.
They should know the options.
There should be a professional sitting with them, going over the options, and the professional should know what that patient is better off always knowing the personality of the patient, what the patient's needs are, what their desires are, thrashing that out and coming to logical solutions that can vary everywhere from major surgery to just watchful waiting.
Yes.
And without that person there, the only someone said once, told me once, the only thing preventing a patient from getting poor medical care, no medical care, is a physician. There's no other answer.
There's another trend. I'm a big believer, and I think certainly I'm very encouraged by this program in coordination of care.
Yes.
As I've worked in healthcare consulting, and certainly my clinical background, that lack of coordination can be fatal. I mean,
it can be a safety measure.
It can be a safety measure.
Absolutely.
So what's interesting is another phenomenon I'd like to hear your thoughts on is what's called the retail clinics.
Oh, yes. Yeah.
So the retail clinics are interesting.
Another challenge for the medical profession. Right?
Another challenge for the medical profession. But to the extent that the retail clinics bring ostensibly primary care more, but it would seem they don't necessarily answer the coordination aspect.
Oh, no. Well, they're an immediate gratification. They have a role. Most of them are nurse practitioners, and there is always in any medical decision nothing like a physician to do it for you. And if you have a physician in a medical home, any kind of problem, whether simple or otherwise, can be cared for. But they obviously are filling a societal need because people are flocking to them. Hundreds are growing up around the country. And if they stay within their boundaries, probably they can be okay. I think there has to be some attention paid to licensing and to having accountability. And I think the AMA's pointed this out in their latest meeting, and I think it's important to do that. They're supposed to be supervised by doctors, but they aren't on site.
Yes.
And, of course, you know, you take a sore throat, and a sore throat is 90% viral, and then there are some with strep throats that you can pick up on simple tests, usually with pretty good accuracy. But then there's infectious mononucleosis, and there's diphtheria, and there are other entities. So anything that's called simple can be complex. It's just that they're doing what the most common things are, and you hope that the follow-up, that they'll be referred to a doctor and they'll get better. But they're seeing these people on a single shot.
We'll go back to that with a break. This is Ogan Gurel with InTimeTV, and stay right there.
Family and friends can provide the support you need to reduce your risk of cancer, diabetes, heart disease, and stroke. Eat right and get active.
Impossible. It's never too early to start reading to your kids.
Are you prepared for what awaits you?
There are amazing possibilities when you open a child's mind to reading. Log on to the Library of Congress website and let the journey begin.
Welcome back. This is Ogan Gurel. We're having an outstanding discussion, really a lot of great ideas with Dr. Anderson Hedberg, former president of the American College of Physicians. This is InTimeTV with Insights in Medicine. We were talking before the break about how the need for primary care is even greater in this technological age, both with the complexities of the technologies and then also with the interesting demographics where a lot more, obviously, older patients with comorbidities and complex diseases. It's interesting, in the 50s and 60s, the heyday of academic medicine, when really the big shift was occurring into specialties, this big demographic bulge of the baby boomers were all in their 20s and 30s. So they had medical problems, but they were something that was acute.
Any sports injuries?
Sports injuries. A specialist took care of them.
They might be in better shape than I am.
And that was that. So we have a really big demographic shift, and the complexity and chronicity really requires primary care.
And your point is so well taken that the human element, the decision-making, having somebody to guide you through this maze of medical care, high-tech care, is very important. And I think so. I think you're right. The primary care doctor is more important than ever.
Yes. We have, coming close to the end of our hour, a couple controversial topics.
Sure.
Did you want to mention anything else about the retail clinics?
No, I think we covered that.
Yeah. Related to that, here's another concept I want to run by you, Dr. Hedberg. Primary care is a wonderful concept. Especially when we look at it internationally, we see that in other countries, other developed countries, it's documented quality, documented lower cost, etc. But America is a nation of very mobile people, and everyone's moving, you know, etc. And to some extent, that continuity of care, would you say that that's almost a problem structurally and demographically?
Well,
in the
doctors
US?
people are changing doctors all the time.
Yeah.
I think a lot of the stimulus are the health care plans. The employer picks another set of plans for next year, and you have to pick another doctor. That's
right.
The managed care aspect of that has caused some of this. But people are very mobile. But look, if we have the right health information technology, which we don't have, if we have a central point for the record of the patient, a patient can break a leg in Denver, call the doctor in Chicago, and with the patient's permission, a button can be pressed, and the entire medical record of that patient can instantaneously be in possession of. And the same thing goes if you're working in a professional building and you're sending a patient to a consult 3 doors away. It's possible that if the right communications don't take place, you won't even coordinate when you're that close.
Yes.
So I think the HIT part of this, the electronic health record,
healthcare information
extremely
technology,
important, and that can keep up with this maze.
Right.
Much better than we are now, and it's a safety issue. The whole business of ordering medications and knowing if there are interactions. The average Medicare patient, for example, is seeing 5 specialists. The average, and 1 or sometimes 2 primary care doctors at the same time. And the communication is not good in American medicine. And I think they've solved that. You know, the European countries, England, the Netherlands, Australia as well, and all have developed HIT to the point where the electronic health record is being used by primary care doctors 90% to 100% of the time. We're down around 28% have a few facets of it, but in terms of having the entire package that it can offer for health care, it's less than 10% of American doctors.
Yeah, I was reading an Economist article maybe 2-3 months ago about that healthcare information technology, HIT, may finally be entering the market. But they noted that when it comes to doctors' offices, in particular primary care doctors, that was really still far off.
It's far off because
cost.
Because of costs.
Yeah.
And because of there's no standardization of instruments, and the interoperability is poor. So if you can't contact people, it's not going to make a difference. But the main factor with physicians in practice is the cost.
Yeah.
A group of 5 costs about $300,000 to put it in, and then you have a $1,500 a month maintenance, and these people are struggling to keep their doors open, and they're not going out on the market and buying it, and there are hundreds of companies making them, and some of those companies fail, so you may get left high and dry.
Right. I mean, there was from President Bush down through Dennis Brailer and all that.
Absolutely.
There
whole
was
national
initiatives.
network.
What is happening with that?
It's going on. David Brailer, a very
David
fine,
Brailer, excuse me, yeah.
fine man, has left it. He was the original person. He was given an impossible job, wire American medicine in 1 year or something, and he did a great job getting it started. But because of the barriers that we just mentioned, it's very slowly developing. Now, why does England have 100% of their nearly primary care doctors having the EHR? They send it to them in a box. They paid billions of dollars to arm every physician in Britain with these machines, and they sent people in to teach people how to do it because there's a slowdown period as you learn it, and it's there. And they're now doing performance measurement right off their machines.
So which leads to my next controversial question.
All right.
I know you know where I'm going towards. Pay for performance.
Right.
A lot of doctors have their opinions, let's put it that way, about that. And some see it as a panacea. Some see it as a total mess. What is it? What are your views?
We're supporting it. American College of Physicians has been out in front.
For our audience, just briefly describe your view. You know what
it is.
Yeah, what it is.
Well,
quickly.
you submit data on various measures of care. How many of your patients had dilated eye examinations? Diabetics dilated examinations yearly last year, and how many of your patients with renal failure, with diabetes and renal failure, had their creatinine tested, and how many patients had their LDL checked, which should be below 130. And now a program's going on in Medicare, which just started in July, which is actually asking doctors to report on 3 measures. It's a testing of whether doctors will be doing this. It's voluntary. It just started. I have no idea how it's going. I know it's a little bit complicated, but people in the practice I was in, I talked to one of them this morning, are doing pretty well with it. We think that doctors should know if things are measurable and they're not going right, they should know for their own sake that they have to improve. So we have acted on that basis, but also pressure from employers and Medicare it has some return
right back to that. This is InTimeTV, Insights in Medicine. I'm Ogan Gurel. See you shortly.
This is fine. Thanks.
Welcome back. I'm Ogan Gurel with InTimeTV, Insights in Medicine with Dr. Anderson Hedberg. We've had a wonderful hour, fast coming to a close. I want to quickly follow up with your thoughts on pay for performance and then a couple last questions.
Well, I think pay for performance is a work in progress, and it's got to be tested in the widespread American medical system to see how it works. It's working fairly well in England, and they've done it in other countries. I think there are major problems we have to look at, being sure that they're adequate, that they're valid, the measures, make sure they're feasible to implement in a doctor's office, make sure there aren't unintended consequences, like doctors refusing to take care of sick patients because it'll hurt the numbers.
Yes.
A very bad outcome. We need risk assessment to correct that, and the rewards are sufficient. If the rewards aren't sufficient, doctors won't jump into it. So those are the basics. It's going to play out in our system. Stay tuned.
Stay tuned, exactly. Right. So last minute or so, I couldn't help but notice in your bio that you are the physician for the tour physician for the Chicago Symphony Orchestra since 1978. Without revealing patient confidentiality or compromising, do you have an anecdote or two you can tell us in the next 10, 15 seconds?
It's a great experience. I did it for 27 years and just turned it over to my associate recently, who's going on their next tour in November. And he'll do a great job. But it's been a wonderful association with a great orchestra. And I think that people who play these instruments at that level in the world really are just very much like doctors in the sense of devotion, skill, professionalism.
Well, thank you, Dr. Hedberg. I've enjoyed your time here. This is Ogan Gurel with Insights in Medicine. See you next week.